Hey, good morning, class. I hope everybody's doing well, and I hope you're all enjoying your weekend. Today, we'll be talking about some disorders associated with the endocrine system. I divided the endocrine system into three parts, and this is actually the third part of the endocrine disorder discussion. The first has something to do with the introduction and, of course, the pituitary disorders. And the second, I was discussing something about the thyroid and hypo and hyperthyroidism. And today we will be talking about disorders associated with the adrenal glands, particularly adrenal insufficiency and oversecretion of adrenal hormones. Alright, so let's talk about this. Again, like I said, I've mentioned this several times in the past during our discussions. The adrenal gland or the suprarenal gland sits on top of the kidneys, and of course, since you have two kidneys, then you also have two adrenal glands. You have the outer layer of the adrenal gland called the cortex, and the inner layer is called the medulla. The cortex releases your triple S, your sugar or cortisol, your salt or the mineral corticoids, or sometimes called aldosterone, and of course your sex hormones known as the androgens. The inner layer of the adrenal gland secretes catecholamines, of course, with the stimulation of the sympathetic nervous system, and those catecholamines include epinephrine, norepinephrine, and to a certain degree, some dopamines. So, one of the most common questions, not just in NCLEX but in HESI also, is a condition associated with formation of a tumor, adrenal medulla tumor, and this adrenal medulla tumor can actually secrete or release too much or massive amount of epinephrine, norepinephrine, and to a certain extent, again, like I said, dopamine. So these are catecholamine secreting tumor, and usually it arises from the chromaffin cells in the adrenal medulla, right here. And what are the some of the clinical features of pheochromocytoma? Normally, I'm discussing pheochromocytoma along with cellular aberration in med-surg or cancer, but since it's part of the discussion in your book, then let's talk about some of the clinical features of pheochromocytoma. Number one, pheochromocytoma is common in adults between 30 to 50 years old, and it doesn't matter, whether you're a male or a female. Usually, it's benign. 9% of the pheochromocytoma cases is benign tumor, and only 10% is malignant. The problem is, it's not so much about whether it's benign or malignant. The problem is the effect or the impact that it can cause if you have too much secretion of catecholamines, particularly epinephrine and norepinephrine, that causes all the signs and symptoms of hypertension and tachycardia. High levels of catecholamines, usually secreting norepinephrine, but then again, like I said, when you say catecholamines, you're talking about not just norepinephrine, but epinephrine and dopamine as well. Clinical presentation of patient with pheochromocytoma, they will have episodic or sustained hypertension, and this has something to do with norepinephrine causing the contraction or rather constriction of the blood vessels, and so therefore it will cause an increased pressure exerted by the blood against the blood vessel wall, leading to hypertension. The patient will have hyperhidrosis or excessive sweating, coarse palpitation because of an increased heart rate associated also with increased catecholamine release, hyperglycemia because epinephrine and norepinephrine can facilitate glycogenolysis, meaning if epinephrine and norepinephrine are released, being the fight or flight hormones, then it will cause release of glucagon from the islets of Langerhans in the pancreas, the alpha cells, causing release of massive amount of glucagon that can lead to breakdown of stored glycogen from the liver and of course from the skeletal muscles, leading to hyperglycemia. And because of the increased glucose level in the blood, of course you will have glycosuria or presence of glucose in the urine. um, Macroscopic features for pheochromocytoma, again, it will appear as a mass. It can actually cause a little bit of, loss of blood due to hemorrhagic situation. In 10% of cases, both adrenal gland, adrenal medulla will have the chromocytoma or the pheochromocytoma, and 10%, only 10% are extra adrenal, meaning just outside of the adrenal gland. Um, a lot of times it will cause hyperplasia of the cells. And again, like I said, it's not hypertrophy, but rather hyperplasia or an increase in the number of cells that can release all those catecholamines. So, with pheochromocytoma, there are three most important symptoms or classic symptoms. And of course, you have the five H's of pheochromocytoma as well. Well, when you say triad of symptoms, patient will be complaining of severe headache, and sometimes, complain of the headache. Can be the most innocuous complaint of the patient, or it could be the most ominous that could suggest really high blood pressure that can lead to stroke or cerebrovascular accident. Again, the patient will have hyperhidrosis or, of course, diaphoresis, meaning excessive sweating. Again, it has something to do with the stimulation of all the sympathetic nervous system and release of those catecholamines. Patients will have palpitations secondary or as a feedback mechanism to an increased blood pressure. Five H's that you have to remember with pheochromocytoma: the patient will have hypertension, and a lot of times this hypertension will not be relieved simply by giving, antihypertensive medication. You need to do a little more than that. The patient will be complaining of headache, hyperhidrosis, or diaphoresis. Don't be confused with that term. Um, Hypermetabolism and hyperglycemia secondary to glycogenolysis. If this is an adrenal medulla tumor, of course, the the usual approach will be to remove the tumor by surgery, like adrenalectomy. Laboratory examinations for pheochromocytoma will reveal an elevated catecholamines, both in the urine and in the plasma, and of course, this can be done by either a 24-hour urine collection or a blood draw if it is in the plasma. You will also notice an elevated metanephrines. Metanephrine is a metabolite of epinephrine. So every time epinephrine is synthesized by the liver, the end product will be metanephrines, and too much of epinephrine release will cause an elevated metanephrine level in the blood. So how do we manage the classic symptoms of pheochromocytoma? The number one concern, of course, is the hypertension of the patient, and you know that it can lead to several fatal complication. So you really need to control the hypertension of the patient as soon as possible, and management should be geared towards managing the high blood pressure of the patient. So we have several medications that can help, like alpha adrenergic blockers and beta adrenergic blockers. Like alpha adrenergic blockers like pentolamine or Regetin, and we have phenoxybenzamine or dibenzoin. For beta adrenergic blockers, propranolol will be the drug of choice, but doctors can actually prescribe other beta adrenergic blockers as well. Why beta adrenergic blockers and alpha adrenergic blockers? First, it helps control hypertension, and at the same time it decreases the heart rate of the patient, which is, remember, the patient will have palpitation aside from having hypertension. Calcium channel blockers can be prescribed as well, and calcium channel blockers are really effective in preventing muscle spasms, particularly of the smooth muscles, and so therefore to prevent any problems like cerebrovascular accidents or a stroke secondary to blood vessel spasms, then calcium channel blockers like nifedipine will be given to the patient. Okay, so again, like I said, if the patient has an adenoma or an adrenal tumor, like adrenal mass, there are three possible complications that can happen. Of course, it will be revealed by history and physical examination, but if you have a cortisol secreting adrenal mass, then it can lead to what we call Cushing syndrome, meaning if you have too much secretion of cortisol, um, the patient will have hyperglycemia, obviously, and the serum cortisol level will be elevated. Um, Diagnostic procedure can be serum cortisol level, urinary cortisol, and sometimes the level of adrenocorticotropic hormone. A lot of times, doctor will also prescribe or order a dexamethasone suppression test by giving 1 milligram, one single dose of dexamethasone, and see what will happen to the cortisol level of the patient. If the patient has a mass in the adrenal medulla, then of course it will lead to what we call pheochromocytoma with the presence of those 5-H's and a triad of symptoms. A lot of times for pheochromocytoma, 24-hour urine collection for catecholamines and metanephrines will be observed to establish the diagnosis, and plasma pre metanephrines, meaning a serum metanephrines, will be evaluated as well. If the mass causes an increased secretion of aldosterone or mineralocorticoids, then the patient will most likely have hypernatremia. So serum potassium level will be evaluated, because most likely the patient can have hypo K, and you know the dangers of having hypo or hyper K. It will cause fatal cardiac dysrhythmias like ventricular tachycardia and ventricular fibrillation. And of course, the aldosterone to renin ratio will be evaluated as well. We'll talk more about that later. Okay, so one of the, I would say, common questions associated with adrenal glands in NCLEX and even in healthy would be the difference between too much secretion of adrenocortical hormones or too little secretions of adrenocortical hormones. If the patient has too little secretions of adrenocortical hormones, then it's called adrenocortical insufficiency, and or sometimes known as Addison's disease. So when you say Addison's disease, it is an uncommon disorder that occurs when the adrenal glands produce too little cortisol and to a certain extent too little aldosterone. So you know what will happen if you have too little cortisol? The patient will be susceptible to hypoglycemia, and too little aldosterone. The patient won't be able to retain sodium. Thus, the patient won't be able to retain water as well. That can lead to polyuria and possibly dehydration. The patient will be excreting large volume urine with specific gravity less than 1.010. What are some of the potential causes of Addison's disease? There are pituitary tumors that can cause um, decreased secretion of adrenocortical or ACTH, adrenocorticotropic hormones. And so, therefore, if you have a pituitary or if the patient has pituitary tumors causing that, then the adrenal gland will not be releasing any of those adrenal cortex hormones, and that can lead to Addison's disease. Postpartum necrosis of the pituitary gland. This is also not common, but it can happen. I'm sure you will talk more about that in OB. This is sometimes known as the Sheehan syndrome, which usually happens after delivery. Um, for you know uh, after decrease in the supply of blood to the pituitary gland, especially if the mom lost a lot of blood during labor and delivery. Hypophyseectomy, if they remove the hypophysis, obviously, it can cause a problem in the secretion of not just adrenal cortex hormones, but all of the hormones of the anterior pituitary gland, and that can lead to several complications, including insufficiency or decrease in supply of or release of adrenal cortex hormones. Radiation therapy affecting the adrenal cortex can also lead to adrenal cortical insufficiency, pituitary or intracranial lesions, and high dose long term glucocorticoid treatments, such as those with immunosuppress or immunosuppressants or patients who are taking immunosuppressants caused by autoimmune disorders like asthma, for example, SLE. We talk about GPS and HSP. So those are some of the conditions that if the patient is taking long-term exogenous supply of glucocorticoid treatment, then that can suppress the adrenal glands, and so or that can suppress the adrenal glands activity, and that can lead to an Addison's disease or adrenocortical insufficiency. So, moving forward, what are the signs and symptoms associated with Addison's disease? Knowing the function of all the adrenal cortex hormones, then you can probably deduce that one of the most important nursing management if you're taking care of a patient with Addison's disease is to make sure that the patient will not go into hypovolemia and hypovolemic shock, because if the patient is not retaining sodium or the patient cannot retain water because of decreased aldosterone secretion, then the patient won't be able to maintain a good hemodynamic status, meaning the blood supply to the vital organs will be compromised. So the main concern would be prevention of hypovolemia and hypovolemic shock. Patient will be complaining of course, muscle weakness, and this has something to do with decreased cortisol level. The patient won't have adequate amount of glucose available for cellular metabolism. The patient will have anorexia, fatigue, dark pigmentation of the mucous membrane in skin, and of course the patient will have hypotension because of decreased intravascular blood volume. The worst possible complication is what we call Addisonian crisis or Addison's crisis, meaning the patient will have cyanosis simply because there is not enough blood supply to the vital organs. And of course, less blood supply means less oxygen supply. Patient will have fever, secondary to decrease. I mean, the patient will be losing the cooling effect of water in the body. Patient will have nausea and vomiting, and the patient can go into hypovolemic shock. Laboratory examinations that the doctor might order will probably reveal some hypoglycemia. Hypoglycemia secondary to decreased cortisol level. Patient will have hyponatremia since there is not enough aldosterone, and since the patient will be susceptible to hyponatremia, then your another major concern would be hyper K, because that can cause a fatal complication, cardiac arrest or cardiac dysrhythmias. Um, if the problem is the pituitary gland itself, you will notice that the patient will have an increased ACTH, but cortisol will be less, um, meaning the pituitary gland is releasing ACTH, but the adrenal cortex cannot release adequate amount of cortisol, and of course decrease aldosterone level as well. So the management for Addison's disease or adrenocortical insufficiency is to restore the fluid balance, make sure that the patient is getting adequate amount of fluids. The patient most likely will be given hydrocortisone as well, followed with D5LR. Position will be dorsal recumbent with legs elevated. And why dorsal recumbent with legs elevated? This is what we call a modified shock position. So we don't put the patient in Trendelenburg's position anymore. We will just put the patient in dorsal recumbent, flat on back, but the legs will be elevated. So this is a modified Trendelenburg or a modified shock position. Now, I want to go back to hydrocortisone followed with T5LR. T5LR is a better solution for the patient compared to normal saline, because lactated driners has more sodium compared to normal saline. Plus, you will give some dextrose to the patient, because remember the patient has hypoglycemia. So the D5 component of D5LR will provide the necessary dextrose for the patient to avoid hypoglycemia, and the lactated driners will provide all the necessary electrolytes, particularly sodium. If you look at the contents of normal saline and lactated driners in terms of sodium content, normal saline has 145 milliequivalents of sodium per liter, whereas lactated drinkers has 154 max of sodium per liter, and so it will be better to use LR than NS. And again, like I said, the dextrose is just necessary to provide additional dextrose for the patient to avoid hypoglycemia. In some cases, D5050 can be used as well. And I'm not really sure if I talked to you about D5050. D5050 is a hypertonic solution. It means 50% dextrose in 50 mils of solution, and so it will provide immediate dextrose to the patient, preventing hypoglycemia if it comes to a point where D50 needs to be used. But usually D5LR will do the trick. This is a caricature of a patient with Addison's disease. The patient will have bronze pigmentation of the skin, changes in the distribution of body hair, because again it has something to do with decreased release of adrenocortical hormones, particularly the androgens. GI disturbances, the patient will be really, really weak, secondary to decreased blood sugar level. Patient will have hypoglycemia, postural hypotension, so you have to be very careful with the patient, especially during acute exacerbation. Make sure that the patient will not ambulate without assistance, because the patient may just pass out secondary to decreased blood pressure. Patient will be losing a lot of weight because of polyuria, and the patient won't be able to keep the water in, and the adrenal crisis may lead to profound fatigue. There is a term called prostration, not frustration, but prostration, PORS, uh, TRATION, and prostration simply means exhaustion of all the vital vital energy, and that's what we call profound fatigue in a case of Addison's disease. Of course, the patient will be dehydrated, there will be vascular collapse, and sometimes it can lead to renal shutdown or acute renal failure, and this acute renal failure is pre-renal, intrarenal or intrinsic, or post-renal. If your answer is pre-renal, then you're correct, because the problem started above the kidneys, meaning it started with the cardiac output. Because if you have less intravascular blood volume, then it follows that you will have decreased stroke volume and decreased cardiac output. Because the patient won't be able to reabsorb sodium, the patient will probably have an increased potassium level as well. So, decreased sodium or hyponatremia will lead to hyperkalemia that can cause some fatal complications or cardiac arrhythmias. So, here in Addison's disease, it's really easy to understand the problem. Remember the functions of your adrenal cortex hormones. Your cortisol causes gluconeogenesis. So if I don't have adequate cortisol level, then I will be susceptible to hypoglycemia. And your aldosterone, which is your mineral corticoids, helps in the reabsorption of sodium. And if I don't have adequate secretion of aldosterone, then I won't be able to reabsorb sodium. Thus, I won't be able to retain water, and I will be susceptible to dehydration and hypovolemia that can lead to hypovolemic shock and, of course, sudden death. Hypotension will happen, hyperkalemia. Patient will be really, really weak, and sometimes the patient can manifest some signs and symptoms of not just confusion, but sometimes delirium associated with acute renal failure. So, what's your priority again? Priority is, of course, to maintain the hemodynamic status of the patient, meaning hypovolemia must be prevented to prevent hypovolemic shock. So, the fluids is one of the most important management of Addison's disease, especially in Addison's crisis. Alright, so if we have too little secretions of adrenal cortex hormones, there is a condition also where the patient will have too much secretions of all of those adrenal cortex hormones, and that is what we call Cushing's syndrome. Although in most references, when they say Cushing syndromes, they are talking about any condition that causes the adrenal gland to produce excessive cortisol. A lot of times, if you have Cushing syndromes, the cortisol level will be really, really high. That can lead to massive, gluconeogenesis. Um, just a couple of terms that I want to clarify. Cushing syndrome is not necessarily similar to Cushing's disease. When you say Cushing syndrome, it's more of a blanket or an umbrella term, um, referring to all conditions of the adrenal gland that causes excessive production of not just cortisol but aldosterone level as well. In Cushing's disease, this is a serious condition where the cortisol is too high in the blood, but it's not caused by the adrenal gland production, but rather caused by a pituitary tumor causing secretion of too much ACTH. So if it is a Cushing's disease, or rather if it is an increase in ACTH secretion caused by a pituitary tumor, then the term is Cushing's disease. And any condition that causes excessive production of cortisol is termed as Cushing syndrome. So if you look at this, Cushing's disease is just a form of Cushing syndrome, or it's just part of the Cushing's syndrome. If I have Cushing's disease, then most likely I will have a Cushing syndrome. It's just that they want to separate that, or they want to make sure that everybody understands that if the problem comes from the tumor of the pituitary gland releasing ACTH, then that's a Cushing's disease, and a Cushing syndrome is a blanket term for all conditions causing excessive secretion of cortisol. One of the most common cause of Cushing syndrome is, of course, adrenal gland tumors that causes too much secretion of ACTH. Again, this is adrenal gland, not pituitary gland. If it is pituitary gland that secretes the ACTH causing Cushing's, then the specific condition is called Cushing's disease. If it is the adrenal gland, then you call it the Cushing syndrome. There are some tumors other than the pituitary and adrenal gland that can actually trigger the release of ACTH, and this is what we call ectopic ACTH production, such as tumors of the lungs. There are some tumors of the lung tissue that can actually trigger the release of ACTH, and that can lead to what we call Cushing syndrome. Certain medications, especially if used for a prolonged period of time, can trigger the development of too much ACTH and too much cortisol level in the blood, thus leading to Cushing syndromes. Like, for instance, people who are taking hydrocortisone for a long period of time, or people who are taking prednisone for a long period of time, people with chronic asthma and taking some asthma inhalers, your NDIs, or the metered dose inhalers that contains some steroids. If you're using that for a long period of time, then that can cause an oversecretion of cortisol that can lead to Cushing syndromes. And people who are using joint steroid injections, like patients with rheumatoid arthritis, for example, or any type of autoimmune disorders necessit that needs joint steroid injections. So again, just to clarify, Cushing syndrome versus Cushing's disease. Cushing syndrome is a broader definition or a broader condition that causes adrenal gland to produce excessive cortisol level. Signs and symptoms of Cushing syndromes, we have central type obesity, uh, buffalo hump in the neck and supraclavicular areas. This buffalo hump in between the scapulae or in between the shoulders is actually due to deposits of fats or adipose tissues, again secondary to increase release of cortisol. Thin, fragile skin. The patient will have purple stria or purplish bluish discoloration of the skin. The patient can bruise easily as well. Patient will manifest some signs and symptoms of being weak and lassitude, muscle wasting, osteoporosis because of too much cortisol level as well. Patient can develop kyphosis um, due to osteoporosis, and a lot of times it can lead to fracture of the vertebrae secondary to pressure exerted by the weight of the patient against the vertebral bones. Um, Patient will also develop this rounded body with rounded face, and this is what we call the moon face appearance. And again, it has something to do with oversecretions of those cortisol and aldosterone in the blood. Pendulous abdomen, and the patient may develop an excessive hair, particularly in the facial area. And you will notice this sometimes women with beard or with prominent facial hair, that could suggest that the patient has Cushing syndrome. Laboratory examination will probably reveal an elevated serum cortisol level. Of course, urinary cortisol can be prescribed as well, and using a 24-hour urine collection. And I'm not really sure if you're familiar with how 24-hour urine collection is done. You need to have a time started and a time ended. So let's say you started 24-hour urine collection at 0700 today. The first urine will have to be discarded, and you have to start with an empty bladder. So 0700, the patient urinate, you have to discard that urine. But the following day, if the patient urinated or voided at 0700, then that urine should be included in the collection. You need to get the orange jug from the laboratory, and that jug has to be placed in either ice, or in some facilities they have refrigerator for specimen. So you have to put that orange jug inside the refrigerator, or again, like I said, on ice for 24 hours. Um, Overnight dexamethasone suppression test. I think I mentioned this earlier. The doctor can prescribe 1 milligram of dexamethasone to suppress the secretion of cortisol. And if the patient responded, then that's a positive sign of Cushing syndrome. Cortisol saliva testing. If the patient has an elevated cortisol level in the saliva, especially close to midnight or midnight, then again that can be highly suggestive of Cushing syndrome, and this can be done on several nights. MRI can be ordered as well to see if the patient has any pituitary tumor or even adrenal cortex tumor, causing an increase in secretion of cortisol and aldosterone. So other signs, of course, will reveal hyperglycemia, hypernatremia, and hypokalemia secondary to decreased sodium level. And whether it's hypo K or hyper K, remember the patient will be susceptible for cardiac dysrhythmias. Management for Cushing syndrome, you need to reduce the use of corticosteroid if that is the cause. Let's say the patient is taking corticosteroid for a prolonged period of time and it causes an increased level of cortisol in the blood, then the doctor may need to reduce the dosage of your corticosteroid, or maybe reduce the frequency of that in order to manage the cortisol level of the patient. Medications, there are certain medications that can actually control excessive production of cortisol, like your ketoconazole, the mitotane or lysodran, metirapone or metoprolol. You have mifepristone, and this is pasireotide or Signifor. um, Patients sometimes, if it is really um, a pituitary tumor, stereotactic radiosurgery can be done. Highly focused radiation can be delivered to the tumor, and it can stop the production of cortisol. And lastly, of course, you have surgical intervention. If the problem is in the adrenal cortex, then adrenalectomy can be done. Or if the tumor is in the hypophysis or in the pituitary gland, then a transsphenoidal hypophyseectomy can be done as well. Um, a lot of people are a little confused about hypophyseectomy. Hypophyseectomy is one of the probably most innovative surgical procedure done to remove a tumor, particularly a tumor of the pituitary gland. That pituitary gland right there is being housed by this area in the skull called the sella turcica, and this sella turcica houses the pituitary gland. A lot of times, if the pituitary gland has to be removed by hypophyseectomy, it can be removed using the transnasal, transsphenoidal approach. You will not see any surgical incision, or you will not see any surgical scar, because a lot of times the probe will be inserted in the nasal cavity, and this is that probe can pass through the turbinates of inside the nasal cavity until it reaches the sphenoid sinus and then to the sella turcica to remove the pituitary tumor. So I have seen a doctor who uses the upper lip approach. So the insertion sometimes can be done between the upper lip and the upper gum, and it can also remove the tumor using the that approach, still passing the sphenoid sinus. So yeah, a lot of times you won't see any surgical incision. After the removal of the tumor, you just have to watch the patient for any signs of course, infection of the brain such as meningitis or encephalitis, and any sign of leakage of cerebrospinal fluid. But a lot of times this is considered as a minor surgery. So this is a caricature of a patient with Cushing syndrome. Again, thinning of scalp hair can happen, flushed face and moon face, hirsutism or increase in facial hair, secondary to again increased androgen levels, purple stria, pendulous abdomen, thin extremities, but the trunk will be obese. Hyperpigmentation, buffalo hump in between the shoulders, secondary to deposition of fats or adipose tissue, acne, moon face, and the patient will have easy bruising, secondary to an increased cortisol level in the blood. I have a sample question here. A nurse is reviewing the laboratory result of a client with diagnosis of Cushing syndrome. Which lab findings would the nurse most likely expect to note in this client? So I will give you a couple of minutes to answer this, and maybe not. The answer would be B, because a blood glucose level of 110 is normal, WBC count of 6,000 is normal, potassium level of 4.5 is within the normal range as well. But a sodium level of 155, that's really high, highly suggestive of hypernatremia. Another question, during the first 24 hours after a client is diagnosed with Addisonian crisis, which of the following should the nurse perform frequently? Diagnosed with Addison's crisis, which of the following should the nurse perform frequently? Weigh the client, test urine for ketones, assess vital signs, administer oral hydrocortisone. Um, the best answer here would be C. You have to assess the vital signs of the patient, because you have to remember the patient is susceptible to hypovolemia and hypovolemic shock. So you really need to monitor the vital signs of the patient. I know some of you may be thinking, weigh the client. Weighing the client is important, but you don't do that every 15 minutes. You don't do that every hour during Addison's crisis. You weigh the patient daily to check whether the patient is losing too much water or gaining weight by retaining the water. Um, but the vital signs is very critical. So there you go. Um, I will be posting another video related to disorders associated with parathyroid gland, the hypoparathyroidism and hypoparathyroidism. Thank you very much, and good luck on your exam. Bye.